Well, yeah, and see, and that's and that's the other reason that we kind of wanted to develop it this way as you know not necessarily not for chronic wounds. We looked at it as more, all right, use it once, use it twice, and then do whatever you normally do. Let's just help make the wound a more healthy wound, so that then you can do whatever standard procedure you want. So say somebody they're a big Integra user. All right, well use the powder for a few days first and then put the Integra on if you want. Or, you want to graft it, you want to flap it or whatever, use the powder first, get a better vascularized, wound bed, and then do it. But, you want to mix it with PRP, go right ahead. You want to mix it with something else, go right ahead. I mean, again, we can't say, oh, do this or do that. But, if somebody wants to do it, then we can't stop them.
Or even something as simple as, and you could probably see the design of the vial. We made it much wider because so often with a tunneling or an undermining wound, you want to create a slurry. You either want to mix it with saline or hydrogel. And I just did this with a really deep pinital cyst where I put the saline right in that vial and took a huge gauge syringe, obviously without the needle, and then put it into the syringe, mixed it up, and then flushed it down into the pinital cyst deep wound. And we saw the patient like 4 days later, and oh my gosh, she was doing incredible. So it does.
So, I mean, do you think, like, for the guy that I did the other day, I just put it on a piece of Adaptic and gauze, and then just put it right on the wound. Mm-hmm. I mean, do you think it's better to make a slush out of it and put it on, or?
I mean, me personally, I think it's better if you've got a wet wound to just apply the powder straight to the wound and just let it absorb the wound fluid, blood, or whatever, and then cover it with a non-adherent dressing like a petroleum gauze or Adaptic or Mepitel or something like that.
Mm-hmm. Right.
Yeah, I just put the way I did it, instead of putting it on the. I only do it the way you did in the picture if it's like a really hard to get to area, like underneath the foot or like the heel where it's really hard to pour some of the powder on. But I just tap the vial like lightly until the powder comes out and sprinkles on it, and you have a nice coating. And if it's drier, then I'll put like a little bit of hydrogel on top or Vaseline or something, and then the non-adherent, just to make sure it doesn't dry out.
But yeah, I mean, if you've got a wound like on the bottom of the toe, big toe or whatever, and you can't ask them to stand on their head to sprinkle the powder on. So, I mean, you could just drip a little saline in there and just make it into a little, putty or a cake, and then just scoop it and smear it into the wound like spackle, basically.
Right. But if you're not seeing if you're seeing them in your clinic, depending on how often you see them, like I'm assuming once a week, is that right? You don't have to worry. I mean, you can't really mess it up. I mean, you can't put too much. I mean, the worst case scenario, if you have a superficial wound and you use too much powder, is you could possibly get some hypergranulation. But for your patients, like that's the least of your concerns. It's not like if you're a plastic surgeon doing a Mohs procedure on the head. You know what I mean?
Right.
So you can't hurt by putting some on there. Putting a healthy amount, and then covering it up. It's either going to work perfectly, or when they come back, maybe they'll still have some remnants of the powder. You'll see that yellow caramelized color, and I mean, you know what to do with that. Just leave it alone, and if there's either cover it right back up, or if there's any red, beefy granulation tissue, then put a little bit more powder and cover it up. But you can't really mess up by putting too much on an open wound. It's only the surgical wounds that you have to be more concerned with putting a light dusting. And then just going back to procedures, yeah, I mean, we talked about surgical, absolutely. Also, though, we talked about like trauma, orthopedic trauma. I mean, they kind of see things. Did we talk about this? Like, what's it called? What's that called? What am I trying to say? Prosthetics, like, savoring the joint, because you can grow the skin over below the knee versus above the knee. Like we've done where we've been able to get the skin to cover the entire joint, so therefore they could salvage the joint and have a below the knee amputation instead of above the knee. Or, necrotizing fasciitis. Burns is my personal baby. I mean, I'd love to help those patients, because if you can help either heal the donor site quick or help the graft take better, and help prevent contractions and scar tissue so they have full range of motion, you know, like in their hands or their neck. I mean, that's just to me very rewarding. You know, think about a kid in a fire. They have surgical revisions as they get older because they have so much scar tissue. So if we can help minimize that, then they could have less chance of having more surgeries as they grow.
Right. No. I mean, that's all good. You know, and I totally agree with that. So.
But does that help you though, as far as like when you're talking in the committee, or not really?